I welcome you all for yet another session of Brain on Wednesdays. We are talking today on the metabolic syndrome, and Dr. Priyanka Banokar is going to be the speaker, and Dr. Maithili Umate is going to chair the session. Can I please ask Maithili to take over and request all the others to mute their mics? Maithili, the platform is yours.
Thank you, sir. Good evening, everyone. Today we are coming up to a nice, refreshing topic on metabolic syndrome, which is quite an important topic. As we speak, we have a speaker today. It's a pleasure to introduce her. She's Dr. Priyanka Banokar Pandey, who's been the founder and director of Mental Health Central in Navi Mumbai. She is the honorary consultant psycho-oncologist in Tata Memorial Hospital, and she has 7 publications and has won the prestigious South Railway Hospital Madras Award. She has been the editor in IABP. Her areas of special interest are psycho-oncology, perinatal psychiatry, neuroscience, and genetics. So I would like to invite her to start the session. Dr. Priyanka?
Yeah, thank you, ma'am, for the kind introduction. Good evening, everyone. At the outset, I would like to thank Dr. Malay sir, Dr. Rajkumar sir, Dr. Bhaskar sir for giving me the opportunity to speak on this topic. I'll share the screen now. Is it visible?
Visible.
Yes.
Okay.
We'll have to go to full screen.
Yeah.
Okay.
Yeah. So let's start. So what is metabolic syndrome? In simpler terms, it's like a triad of pre-diabetic or diabetes, normal blood pressure or hypertension, and atherogenic dyslipidemia with obesity. Now, in metabolic syndromes in South Asian, it is different. Different factors in different geographical locations. So in South Asian, there is increase of diabetes and increase of cardiovascular disease. And the reason being, we have higher percentage body fat, ectopic fat, and central obesity. That is, our body composition is different. Our traditional diet is more carbohydrate, and which is has a risk to cause obesity. There are higher LDL levels in our due to our genetic makeup, which leads to dyslipidemia. Other factors like vascular and higher risk of insulin resistance. Also, cultural and social factors are also responsible for metabolic syndrome in South Asians. Coming to etiopathogenesis. Now, why do we need to know about the etiopathogenesis? Mainly for early detection of the metabolic syndrome, so that we can find out novel means of treatment. We can classify based on new biomarkers, and we can and it can lead to discovery of potential targets for therapeutic interventions. There are 3 established ideas in pathophysiology. First is insulin resistance. There is also hormonal activation and chronic inflammation. Now, this figure tells you how it works. So, due to visceral adiposity is there, which leads to increase reactive oxygen species and increase RAS, which leads to increase angiotensin 2. There is also increase in interleukin 6, TNF alpha, CRP, fibrinogen. There is increase in leptin and adiponectin and chimerin. There is increase in free fatty acids. All this leads to chronic inflammation, hormonal activation, and insulin resistance, which in turn leads to metabolic syndrome, which leads to diabetes and cardiovascular diseases. Now coming to insulin resistance. So there is impaired insulin mediated inhibition of lipolysis in insulin due to insulin resistance, which leads to increased free fatty acids, which again worsens insulin resistance by causing alteration in insulin signaling cascade in different organs, leading to increased triglyceride, cholesterol esters, and VLDL and decreased HDL, which in turn leads to dyslipidemia, and later on increased risk of cardiovascular diseases. Due to loss of insulin's vasodilatory effect and free fatty acid induced vasoconstriction due to reactive oxygen species production and nitric oxide, there is hypertension. Higher serum viscosity and prothrombotic states and increased pro-inflammatory cytokine release, all due to insulin resistance, leads to cardiovascular disease and type 2 diabetes mellitus. Now, there are certain insulin sensitive regions in the brain, which are hypothalamus, which leads to homeostasis. Insulin has a region in hippocampus. That's why there is issues when coming to memory. Striatum, lateral prefrontal cortex, and attention, fusiform gyrus, insular cortex, and orbitofrontal cortex and anterior cingulate cortex. Now, in diabetes, there is insulin is secreted by a pancreatic islet, that we know. So, when there is increased stress or increased glucose in the metabolism, there is increased synthesis of insulin. That is, beta cell function due to glucose sensing increases. And with time, when there is increase in glucose and fatty acid metabolism and amyloid toxicity and also stress responses, the beta cell function gradually decreases. So initially there is increase in beta cell mass, which is normal state, and with stress, increase in stress response and lose cell death, that is beta cell mass, is if it is lost. So it leads to increased glucose tolerance and type 2 diabetes. Now we also know that brain insulin resistance is there in obesity and type 2 diabetes, but it's also associated with aging and dementia. So that's why diabetic patients have high risk of dementia with time. Now, insulin resistance and its association with sex hormones and metabolic syndrome. So, mainly estrogen. So, estrogen receptors, mainly E2, estrogen receptor alpha, they have a sensitivity, and they are present in peripheral organs as well as brain. So, in brain, it increases energy expenditure, decreases food intake, which leads to body weight and adiposity. So, and in other tissues also, it helps in decreasing pro-inflammatory cytokine secretion. It protects against lipotoxicity and apoptosis in pancreas. In liver, it enhances hepatic insulin sensitivity and suppresses liver fat accumulation. And that's why we have a difference that in sex differences in metabolic syndrome. That is, young females are less prone to getting diabetes than postmenopausal women. And later on, the risk of
हो काही
diabetes
दिवस त्याला
in
संध्याकाळचं माझं
postmenopausal women and men
Continuation
is
service.
similar.
Please, sorry, Priyanka. I request all the attendees to please mute their mics. Carry on, Priyanka.
पण नंतर बोलूया का मी जरा कामात आहे मग तुमच्यासाठी मला काहीतरी स्पेशल अरेंज करायला
Gentlemen, please mute your
काही
mics.
नाहीये मला ना मला काहीतरी अरेंजमेंट करायला लागेल तुम्ही मला उद्या
भाऊ तुमचा माईक जरा बंद करा ना. ऐकला का? Yeah, carry on, Priyanka. Sorry.
Yeah. So men and postmenopausal women, because estrogen secretion decreases with menopause, they have similar risk of diabetes. Now coming to androgen. So even androgens play a role in regulation of insulin resistance and energy homeostasis. In males, it is found that low testosterone is associated with insulin resistance, and in female, hyperandrogenism predisposes to type 2 diabetes, which we find in PCOS, which is polycystic ovarian syndrome. It has hyperandrogenism and insulin resistance. But androgen receptor deficiency has no significant effect on energy metabolism as such. Now coming to adipose tissue, which is now considered as an endocrine organ. It is a thermoregulator and a lipid storage facility, as we know. The adipokines secreted through adipose tissues are hormones, for example, leptin and adiponectin, peptides, angiotensinogen, apelin, resistin, plasminogen activator, inhibitor, and inflammatory cytokines like IL-6, TNF alpha, visfatin, omentin, chimerin, which all together leads to insulin resistance and later on to metabolic syndrome. Now coming to hormone leptin, decrease in leptin levels below the usual adaptive level, it causes increase in eating and decrease in energy expenditure. And but increase in leptin level above usual level has little effect. And now long-term obese person, they have increased eating and decreased energy expenditure when leptin is reduced to levels that are still much higher than those in never obese persons. It is actively transported through blood-brain barrier, which leads to eating, energy, and HPG axis function also. And it has a role in phagocytosis, T cell activation, and hematopoiesis. Leptin levels, it has been found to be directly proportional to obesity and body fat levels. And in leptin resistance, there is a decreased sensitivity to leptin, which promotes a pro-inflammatory immune response and reverse the starvation-induced immunosuppression. Higher leptin levels in turn increase cardiovascular risk and inflammation, and that leads to metabolic syndrome. Adiponectin, which counter the effects of leptin, it has an anti-arrhythmogenic, anti-inflammatory, and anti-diabetic effect. In depression, there is low leptin levels, and later on, and
Gentlemen, please mute your mic.
Hemanshi, please mute yourself.
Can the co-host mute others?
Muzaffar, आप सबको बंद सकते. Dr. Hemant, can you please switch off, mute your mic?
I will do that, sir. Done, sir, done. Go ahead, ma'am.
Okay. So depression it is found that in depression there are low leptin levels, and in serotonin dopamine antagonists, which are antipsychotics, they lead to high leptin levels.
Priyanka, just a moment.
Yeah.
Sir, that voice coming from your end, sir.
Okay, carry on, Priyanka.
Okay. So as we saw, leptin levels, there is a low leptin levels in starvation and leptin hypersensitivity, which leads to hyperphagia, and in obesity there is leptin resistance, and so there is increased food intake, steatosis, and insulin resistance, and excess adiposity. Now coming to renin-angiotensinogen system, it is secreted by adipose tissue, and it's a peptide which is after activation of ACE, and activation of nicotinamide adenine dinucleotide phosphate NADPH oxidase. It leads to activation of NADPH oxidase, which in turn leads to reactive oxygen species, and which later on causes endothelial injury, expression of NFK beta platelet aggregation, oxidation of LDL, and hence dyslipidemia and other things. So renin-angiotensin system and reactive oxygen system, they have a positive feedback loop, which later on leads to endothelial dysfunction, inflammation, fibroblast proliferation, and it leads to progression of dyslipidemia. So the third factor, chronic inflammation. So in metabolic syndrome, there is increased expression of leptin, chimerin, fibrinogen, and other things, and there is decreased expression of adiponectin, omentin, and IL-10. Yeah. So coming to hormones produced by and GLP, coming to glucagon like peptide 1, it is produced by enteroendocrine L cells in small and large intestine, and by small population of neuron in nucleus tractus solitary. All three macronutrients, they lead to intestinal GLP-1 secretion, and it elevates for hours after meals and return to basal levels only overnight. It functions as a postprandial satiety and or across meal satiety signals. That's why we have GLP-1 agonist like liraglutide and semaglutide, which are being used in for the treatment of obesity and reducing eating and body weight. So about GLP-1, it like we can see in the figure, it works on many organs, and mainly in liver it leads to glycogen storage. In brain there is neuroprotection. Heart it increases heart rate, myocardial glucose uptake, and decreases ischemia induced myocardial damage. And in pancreas, it decreases beta cell apoptosis and increases insulin biosynthesis, and helps in insulin sensitivity, and so in other organs. So now coming to reward network. So food, as we know, it's causes a pleasure like symptom. So we like to eat. So the as we have found out that through studies that it's like a reward, and the areas which are in the brain which are activated are just like when they are activated during when we take drugs or have sex. So these are the regions which are activated after intake of food, which are similar to which is the actually the reward network. So now coming to gut microbiome. This is the recently research topic. So as we know, there are, and it plays a role in metabolic syndrome and obesity. As we know, there are numerous bacterial population present in the gut, and the dynamics of regular nutrient-induced growth of bacteria are similar to dynamics of meal-induced intestinal satiety hormone release. So bacterial molecules and metabolites, they regulate intestinal release of satiety hormones. Systemic bacterial molecules directly activate central appetite pathways that might integrate the energy status of both host and its gut microbiota. Microbiotal gut signature is present not only in human obesity but also in type 2 diabetes mellitus. Other novel factors are also being researched for development of metabolic syndrome, which are fituin A, mitochondrial dysfunction, and PGC alpha 1, circulatory microRNAs, and others. Now coming to psychiatric illness and metabolic syndrome. We know that our patient have genetic predisposition to metabolic syndrome, and it is multifactorial in nature. Other factors are excessive alcohol consumption, poor dietary habits, and gut microbiome alterations. There can be hormonal imbalance involving cortisol and leptin. And we know that second generation antipsychotics, they have increased risk to cause metabolic syndrome, and also sedentary lifestyle. So these are the psychotropic medicines which are associated with cardiometabolic adverse effects. Weight gain, we know antipsychotics, most is with clozapine and olanzapine, quetiapine, risperidone. In mood stabilizer, valproate and lithium also. Antidepressant, mirtazapine, tricyclic antidepressants, MAO inhibitors, and other antidepressants except bupropion. In dyslipidemia, same molecules. Diabetes also are similar. Hypertension, psychostimulants, mainly amphetamines, methylphenidate, other stimulants, and atomoxetine. Antidepressants, mainly SNRIs, TCAs, and antipsychotics, aripiprazole, clozapine, olanzapine, ziprasidone, as well as mood stabilizers like valproate acid. This is a chart showing low to moderate, low to high risk of weight, increase in weight after the intake of medicines. So bupropion and lamotrigine has the lowest risk of weight gain. Also duloxetine, SSRI short term, other SSRIs, duloxetine long term, and cariprazine, lurasidone, ziprosidone, even lithium. And in high, it's olanzapine, clozapine, alloperidone, mirtazapine, amisulpiride, and amitriptyline, TCAs. Now coming to management and prevention. So basic diagnostic criteria are abdominal obesity, waist circumference more than 88 centimeter, more than equal to 88 centimeter in women, and more than 102 centimeter in men. or BMI more than 30 kg per meter square. Additional diagnostics criteria are pre-diabetes or elevated non-HDL cholesterol levels, high normal blood pressure or hypertension. So that is systolic blood pressure of more than 130 or diastolic blood pressure more than 85, or the patient is on antihypertensive treatment. Similar with diabetes and dyslipidemia. Now, these three we know are the main diagnostic criteria: hypertension, diabetes, and dyslipidemia. But other comorbidities are also there in metabolic syndrome. Like there is impaired kidney function, fatty liver disease, heart failure with preserved ejection fraction, obstructive sleep apnea, polycystic ovarian syndrome, sympathetic activation and tachycardia, hyperuricemia, and chronic inflammation. This is the increased risk with age, and increased cardiovascular risk with age. Now, if there is abdominal obesity or BMI more than 30, then these are the diagnostic criteria which I have already told. So fasting blood glucose and HbA1c levels to be done, and lipid panel non-HDL cholesterol levels to be done. And if it is raised, then it is metabolic syndrome. Other components can be oral glucose tolerance test, serum creatinine, and liver hepatosteatosis, serum hyperuricemia, and other specialist assessment might also be needed depending upon the symptoms, as we have seen in the comorbidities. Now, the robust biomarkers are of metabolic syndromes are high triglycerides in serum and raised uric acid serum levels in an associative manner with NAFLD and type 2 diabetes mellitus. It is NAFLD is a non-alcoholic fatty liver disease. It's an early risk factor. So if it is diagnosed, then the treatment needs to be started. And it can lead to early diagnosis before development of any other comorbidities. Muscle strength is early risk marker for cardiometabolic health. Now, coming to the treatment part. So what are the indications of treatment? Firstly, dietary modification is needed if there is obesity, impaired glucose tolerance, hypertension, or dyslipidemia. Decrease of simple carbohydrates, decrease of trans fats and saturated fatty acids, and increasing the intake of omega fatty acids, and decrease the intake of salt. And to increase the physical activity, which can be 150 to 300 minutes of moderate intensity or 75 to 150 minutes of vigorous intensity aerobic physical activity per week. Also to reduce alcohol intake, stop smoking, and to maintain a sleep hygiene. Now, depending upon the indication, the treatment target is there, and steps are given what to be done next. So if the BMI is more than equal to 27, the treatment target is to lose weight by 5 to 7%, and for that GLP-1A receptors agonist can be used. And step 2 naltrexone and bupropion combination is there available in US, UK. So that can be used. Another is orlistat. And the last step is metabolic surgery. Same with diabetes. So if diabetes is diagnosed, that is if HbA1c is less than 7%, or this is the target to be achieved, to HbA1c to be decreased to less than 7%, or maybe consider 6.5%. So metformin and GLP-1A receptor agonist can be given. SGLT2 and other oral medications can also be given. Hypertension, the target to be achieved is BP less than 130/80, and first line of treatment is ACE inhibitor, or angiotensin receptor blocker, or calcium channel blocker, or thiazide diuretic. And here the step 2 would be, if it is not being controlled, if the target is not achieved, then to add all the three. And the next step would be addition of aldosterone antagonist and beta blocker. About dyslipidemia, the target should be LDL less than 70 or 55 milligram per deciliter, and statin at maximal tolerated dose is the first step, and ezetimibe is the second step, addition of ezetimibe. And if the triglyceride are still more than 200, then addition of fenofibrate and omega-3 fatty acid is required. Now, what weight loss of 5% is considered to be have a better glycemic control, blood pressure, and lipid profile. It also reduces type 2 diabetes mellitus and is cardiovascular complication. Greater the weight loss, more significant is the expected improvement of carbohydrate and lipid metabolism and blood pressure. Metformin, we know it is given to prevent the development of diabetes mellitus in those aged less than 60 with BMI more than 35, and women with a history of gestational diabetes. It can be used in the treatment of, it is actually used in the treatment of diabetes also, concomitant overweight or obesity, atherosclerotic cardiovascular disease, and chronic kidney or very high cardiovascular risk. It is used with another agents for better glycemic control. Now, GLP-1 RA1 receptor antagonist is used when BMI is more than 27 kilogram per meter square to reduce the risk to progression to type 2 DA. It can be given with sodium glucose cotransporter 2 inhibitor like canagliflozin, dapagliflozin, and empagliflozin. All these are not available in India. Now, about GLP-1 RA receptor agonist, liraglutide and semaglutide. Liraglutide has a target dose of 3 mg, and semaglutide has a target dose of 2.4 mg. So it is mainly used in cases of overweight and obesity with comorbid metabolic syndrome, pre-diabetes, type 2 diabetes, hypertension, atherosclerosis, and also its clinical sequelae like obstructive sleep apnea, fatty liver disease, or polycystic ovary syndrome. And it is also used for treatment of obesity before or after bariatric surgery. Statins, as we have seen, it decreases epicardial fat and inflammatory markers in patients with coronary artery disease as well as metabolic syndrome. Now, DPP-4 inhibitor sitagliptin, it regulates adenosine monophosphate activated protein kinase. It decreases metabolic syndrome, obesity-induced adipose tissue inflammation, and fatty liver. It also has a positive influence on hyperglycemia-induced vascular changes in an endothelium-dependent manner, which decreases visceral adiposity as well as maximal response to oral GTT in women with PCOS. These are the other newer molecules. Pioglitazone is a peroxisome proliferator activated receptor. It causes insulin sensitization and enhanced glucose metabolism. It is involved in regulation of energy homeostasis, and it enhances fatty acid metabolism. Now, coming to treatment of antipsychotic related weight gain, treatment which have been studied, this is a chart about that. So, amantadine, melatonin, orlistat, topiramate, reboxetine, and zonisamide. This data is available from RCTs in antipsychotic treated patients, and this treatment are available, but they are not necessarily licensed for treatment of obesity, but that they have been used in studies and have found to be effective. Bariatric surgery, GLP analogs, and others, they have evidence of efficacy in general population, but they have the trials have not been done in antipsychotic treated patients. And atomoxetine, dextroamphetamine, famotidine, fluoxetine, fluoxamine, nizatidine. This for most of this treatment, only a single negative clinical trial has been carried out in antipsychotic treated patients. This difenfluramine, phenylpropylamine, rimonabant, rosiglitazone, and sibutramine has only limited or no evidence of effectiveness in antipsychotic related patients. Now, coming to bariatric surgery, when it is done and what is the target. So, permanent related weight loss, and if we need a remission from obesity related diseases such as type 2 diabetes, hypertension, and dyslipidemia, then bariatric surgery is indicated. Criteria for bariatric surgery are BMI more than 40. If the BMI is in the range of 35 to 39.9, and there is one or more than one obesity related disease like diabetes, hypertension, severe osteoarthritis, dyslipidemia, or severe obstructive sleep apnea. And if BMI is in the range of 30 to 35 and type 2 diabetes mellitus is uncontrolled despite appropriate medical treatment. And if preoperative weight loss is 5 to 10%. Now, what are the coming to prevention? So, as we have found out that we know about metabolic syndrome, how to prevent it. So, we need to take care of pediatric population who have increased risk for metabolic syndrome, and start the prevention early. So these are the major risk factors for pediatric obesity. Factors which are present at birth are fetal programming like epigenetics, genetics we already know, and developmental disabilities, behaviors like poor nutrition, insufficient sleep, fast food, increased snacking, decreased physical inactivity, obesogenic medications which are needed in certain pediatric patients, home environment like parental feeding style, environmental smoke exposure, psychosocial stress, and adverse childhood experiences, endocrine disruptions, and social determinants of health, which actually are not in our control. So these are the certain strategies which can be used for prevention of pediatric obesity from antenatal period till adolescence. So antenatal factors which can be promoted is healthy diet and daily exercise, antibiotic use only when necessary, healthy BMI, pre-pregnancy levels should the pre-pregnancy BMI should be in healthier range. Avoid excess gestational weight gain. Regularly test for gestational diabetes and avoid smoking consumption. These are the antenatal factors. About antibiotic, this is related to gut microbiota. So that's why it is advised to use antibiotics only when necessary. Infancy factors can be should be advised to avoid starting solid foods before 4 months to avoid it. Breastfeeding is protective of, so should be advised till exclusive breastfeeding should be advised till 6 months. Sleep duration should be more than 11 to 12 hours from birth to 2 years. To avoid sugary beverages and limit sugar intake from birth to 2 years. Avoid rapid weight gain in infancy. And if formula feeding, to use low protein formula and appropriate bottle feeding practices. And in childhood and adolescent factors, uh, parental modeling of healthy eating practices, availability of healthy food at home, minimize screen time and exercise 60 minutes per day, 8 to 11 hours of sleep at night. And if there are any psychiatric symptoms, refer to the clinician. And if there is food insecurity, refer to the social workers. These are the certain strategies for used for prevention of obesity in pediatric population. So thank you. That's it. Now I'm open to questions.
Maithili, you take over now the moderation.
Yes. Yes, Dr. Priyanka, thank you for such a clear and comprehensive presentation. You have given a lot of emphasis on the biological basis, and it is very nice that you have also mentioned the preventive strategies, especially in the pediatric age group. I would also like to add a further comment that there is a mixture of like sedentary lifestyle, which is highly seen in India. A recent Lancet study also said that, along with unhealthy lifestyle and the use of psychotropics. So, the non-communicable diseases, the NCDs, are currently the thing. So, it's very important that we monitor and we treat.
Right.
I would also like to ask Sir for his comments. And if there are any questions.
Yeah, let's see. There are no questions at the moment. So One thing is that this metabolic syndrome is a it's an evolving concept. It was initially only weight gain, then the problems that are associated with weight gain, and things like that. So as we understand better, there is also some change in terminology. Now, what was previously known as NAFLD, non-alcoholic fatty liver disease, is now called MAFLD, metabolic associated fatty liver disease. So there's a change in a little bit. It's actually the same thing. But yes, we are even though, and even obesity is something, it's not only related to the BMI. BMI tends to be a little bit of an outdated measure now. Uh, there are other types of obesity. Means a person can have normal body weight as per height and age, but can have a problematic fat deposition, and that can be normal weight obesity. So obesity is not only being overweight. It's basically how the fat is distributed in the body, subcute versus visceral fat. The more amount of visceral fat is problematic because that is where the inflammatory changes happen, in that storage of fat, not in the subcute fat, which we all have. So it's an evolving concept. It's nice to get in topics like this, because we are always talking about stress, anxiety, depression, but uh, those disorders also, our disorders also, are a part of the all these disorders also have metabolic derangements, the micrometabolic derangements in the pathophysiology of the illnesses as well. We have inflammatory etiologies, we have got reactive oxygen species as etiological factors, we have got so many inflammatory factors that are over time change and are associated with any kind of a psychiatric disorder. The genetics of metabolic syndrome also overlaps, and probably that is why we are seeing that many of our patients, the moment we start using atypical antipsychotics or even antidepressants, they start putting on weight. So it's probably not only medication related, but it's the common genetics of a metabolic syndrome as well as the psychiatric disorder, which kind of comes into play. So yeah, Dr. Priyanka, you did a good job of getting all these things, all these concepts in one place. It becomes there are too many things. Of course, it's difficult, and we as psychiatrists are not all the time going to manage all the physical comorbidities of the metabolic syndrome. But we need to be aware now. What has happened is now in the last 2 or 3 years, we have got semaglutide, which has come, and it has kind of revolutionized. Revolutionize is the correct term, of revolutionize the treatment of metabolic syndrome the world over. It's not a cheap drug anywhere in the world, but there are physicians who swear by it, saying that this is one molecule which can manage each and every aspect of the metabolic syndrome that you mentioned. Not only weight, not only HbA1c levels, but also all the other complications like OSA. Weight comes down, OSA comes down. Osteoarthritis. It actually, in many cases, has prevented surgical interventions. So as psychiatrists, we need to be aware, because our patients are going to read something on Google and they're going to come and ask us, where do I get, who is going to prescribe me semaglutide and things like that. So yes, I think some questions have come up. So without taking time, I'll ask these questions. Yes, the first question is, are metabolic side effects of antipsychotics dose dependent, specifically for olanzapine? What do you think?
Yes, I think it is dose dependent. Uh, as we reduce the dose, but it is not the only factors when it comes to metabolic syndrome that I wanted to highlight. When it comes to psychotropics, we think the person is taking psychotropic, that's why he is obese, and then we think of stopping that medicine. But it is not the right strategies. There are other factors also playing in, and like we have found out, there is a genetic predisposition plays a major role in that. So yeah, antipsychotic have I think they have dose dependent metabolic side effects, but if there is no the other molecule is not working, then we will have to work around other strategies to reduce uh, the medicine.
I think with olanzapine or any drug that is probably going to cause weight gain in a patient, uh, even at very low doses, the weight can start increasing. So it is not uncommon that we will find some patient who is on 2.5 milligrams of olanzapine, for example, and 2 weeks, 3 weeks down the line, there is some increase in weight. And of course, when we increase the dose, that increases, but it becomes difficult to actually judge who or who may not
Right.
gain weight and how much. Now, the only thing is that if somebody is already on the overweight side, somebody who already has metabolic disturbances in terms of impaired glucose tolerance or pre-diabetic stage or uh, borderline hypertension, then we have to reconsider whether we want to go ahead or not. That's probably the only thing we can do.
Right, sir.
Dr. Yadav asks a question: is there any specific diagnostic criteria for diagnosing antipsychotic related metabolic syndrome?
There are no specific diagnostic criteria. Same criteria which I have mentioned, we diagnose metabolic syndrome and other comorbid disorders according to. Nothing specific is related to antipsychotics or psychotropics related,
We need to
except for the fact that the person is taking that medicine.
Yes, so that is what I was saying. Medications are one of the factors which lead to the metabolic syndrome. It is not the cause.
Hmm.
The metabolic, whatever you mentioned in terms of the etiopathogenetic factors, that is what leads to the full-blown metabolic syndrome. Other things are like triggers. So medication is a trigger. Whatever category of medication, it's not only our medications. There are other medications which can also lead to or trigger a metabolic syndrome. So these are triggers. So triggers do not have specific diagnostic criteria. They are just mentioned as triggers. The diagnostic criteria remain the same.
Yeah, and I have seen even on olanzapine, some people don't gain weight at all, means even at the dose of 20, 30. So it's not that everyone on olanzapine or psychotropic antipsychotics will have metabolic syndrome eventually.
Okay. Another question that comes to you is any clinically proven molecule to treat non-alcoholic steatohepatitis, NFLD, and visceral body fat? Any clinically proven molecule?
About NASH, vitamin E is given is what, as far as I know, which uh, um, it helps in the metabolism of fat and liver. Other than that, I am not aware of actually.
No,
But yeah,
all the molecules that you mentioned, those different categories of molecules that are associated with T2DM, some of them can also help in management of obesity. Now, we just were talking about semaglutide, liraglutide. These are molecules which do help. The primary effect of these molecules is on appetite. It is not on blood glucose control. So
right.
because they manage the appetite, they manage weight, and because the weight is managed, the complications of T2DM, if T2DM is present, or if the patient is pre-diabetic, the chances of him or her getting into T2DM are reduced. So these molecules can help. Will they help in all patients? No, because this syndrome is multifactorial. But yes, there are specific molecules. That is what we are looking at now. Semaglutide, and now we are going to have tirzepatide. It's semaglutide plus something more, which is a better metabolic control plus appetite control. So it can be used. Dose of semaglutide for obesity, how to initiate? I think we better leave it, because we should be able to do a comprehensive physical exam, all the necessary parameters, and see whether we want to use semaglutide alone or with something else. So that we need a good physician's opinion. This is what in my practice I would do. Semaglutide, if I'm going to start, another thing that is important is that semaglutide will cause weight loss, but is it going to maintain that weight loss in the long run without a comprehensive diet and physical activity program? That is a big question, because there are studies, or rather there are observations, clinical observations, that when semaglutide is used, the weight that is lost initially doesn't remain lost that much. It can come back if that proper program is not in place. And also why we need an exercise program is that if there is only weight loss, there can be muscle mass loss also. Sarcopenia can happen. That can cause its own problem. So if you're going to use semaglutide, we need to be very careful. I would suggest that we should have a physician on board who can also look at other things. So semaglutide, yes, it is there, but we need to be a little bit more careful in using semaglutide. Another question that comes to you is, does family history of diabetes increase the risk for the patient to develop metabolic side effects after starting antipsychotic treatment? You're not, you're mute, you're mute. You'll have to unmute.
Okay, so yeah, any risk factor which is associated with diabetes is going to be an additive factor for other risk factors. So if there is family history of diabetes, that means genetically that individual is predisposed to diabetes. Another thing, uh, the person who is on antipsychotic is has uh, the changes in the body stress response related to the psychiatric illness, which is also a risk factor for obesity. So that also can lead to developing of metabolic side effects. So point being that we can't be sure, but strategy can be to start with effective antipsychotic, and later on try to when the patient is in remission, try to change it to another antipsychotic which has less propensity to cause metabolic syndrome, is what I think.
See, practically, if there is a history of a non-communicable disease in the family, it becomes a vulnerability in the individual to develop that non-communicable disease or other non-communicable diseases, including psychiatric illnesses. So the vulnerability is a complex picture. Now, having said that, and I also did mention that there is, and it was mentioned by Dr. Priyanka also in her presentation, that there is an overlap in the genetics of psychiatric illnesses and metabolic syndrome. So those are not really separable. So the thing is, if there is a history of diabetes, strong history, we may not give molecules like olanzapine or clozapine. But if a patient has already been given and is stable, then we have to kind of monitor all the parameters that have been mentioned uh, uh, with respect to the metabolic syndrome. Another question Dr. Yadav asks is, bupropion with mirtazapine, will it reduce the risk of weight gain?
I don't think so, because one drug is causing a metazapine has increased risk of weight gain, and bupropion is counteracting, as in it has a less risk of. So depending on the dose also, I don't think so that it will reduce the risk of weight gain. It will also depend on the patient. If the patient already has a predisposition to metabolic syndrome, then it won't work, I think.
Yeah, so it's better that we individualize our treatments as best as we can. It is again, we are talking of weight gain. Mirtazapine may not induce weight gain. If there is weight gain, then we may need to use a specific weight loss strategy rather than combining with a molecule which has no weight gain or rather minimal weight gain. So again, Dr. Priyanka had showed us a chart in which the different types of molecules that have been tried in terms of trials, RCTs, or at population level, or and there have been anecdotal experiences. Some of that may work rather than combining with a molecule which has got lesser weight related side effects. So that would be the thing. So that may not work. Yes. Dr. Vaibhavi asks, any guidelines for the duration of treatment for metabolic syndrome? Means how long do we treat? If the target BMI is reached, should the drugs be stopped? Should the drugs be kept at maintenance dose or stopped?
So metabolic syndrome is not just obesity. So we have to take other factors also consideration, like diabetes, dyslipidemia, and hypertension. And for all this illness, all these diseases, we need treatment lifelong, as we know already.
Okay. Dr. Maithili, what has been your experience? You work in an institute, and I mean, when we talk of institutes, we basically think of a different category of patients who visit the OPDs, more severe illness probably. I mean, or what has been your experience? How do you assess, manage, deal with this kind of things, the metabolic syndrome?
Yes. In government setups, we are more likely to see, of course, people from a little poorer strata, where any which ways obesity we see at much higher levels, especially in chronic cases who have been following up for pretty much a long time. Here, as far as treatment goes, there are further challenges in terms of the financial aspects. In private setups, it is much easier to go on with molecules. Most of the molecules mentioned are not available in the government setup, or I'm not sure how many come under the DPCU, so which could be cheaper. So yes, that is pretty much a challenge, especially in government setups where we see people with more severe illnesses, and with very often there is polypharmacy in case of chronic cases.
Okay.
So I think there is one more question. I think we can take that.
The last question is, are some psychiatric illnesses actually a part of the metabolic syndrome if same genes are involved? Well, you can say the easiest way is that, if you have a set of genes and if you have a set of processes, biological processes which are common, then a metabolic syndrome or a psychiatric syndrome are different manifestations of the same processes. So it could be that the initial presentation is a psychiatric syndrome like depression or psychosis or mood disorders. Over time, we see the physical component coming in, or the physical comorbidity coming in, like we would have the beginning of hypertension or beginning of T2DM. It is well known that people who have chronic psychiatric illnesses, this population of patients has got a 15 to 20 year less survival than a patient who does not have a psychiatric illness. So for some, it would start as a psychiatric illness. For some, when all these symptoms start, when all the symptoms of weight, blood pressure, sugar control start, some cardiovascular event happens, or other the cardiovascular pathology starts, we should also assess them for psychiatric symptoms. So for some people, the non-communicable physical components will start first, and then the psychiatric symptoms will be more evident. There are patients, there are people, we see geriatric patients, they come up with symptoms of dementia, and we keep on asking them, was there any psychiatric illness before? Was there anything else before? And they keep on saying, no, no addiction, no psychiatric illness, no anxiety, no depression, nothing. Then they'll say that, no, diabetes is going on for 15 years, hypertension is going for 20 years. So these people, when we have an established one or multiple components of the metabolic syndrome, that is then gets associated with neurodegeneration. What is neurodegeneration? We have cells dying prematurely, cognitive impairment because of poor insulin signaling or insulin resistance, and so many other things. So when we look at the whole picture in terms of pathophysiology and genetics, we can see that there are different populations. Some population has predominant or early psychiatric presentations. Some people have early physical presentations, then later psychiatric presentations, or a combination of things which then present as neurodegenerative. So something like that, because processes are similar. There are chronic inflammation, reactive oxygen species, autoimmune dysfunction, and so on and so forth. Dr. Paresh asks, patient is stable on olanzapine with weight gain. Is it good practice to add metformin? How long should we continue?
I have not used this strategy. I would rather, if the patient is stable, try to put him on another antipsychotics like aripiprazole, then adding one more molecule, because our patient, as it is, don't want to take too many meds. So adding a pill burden is another issue. So that is my point of view. But yeah, sir, ma'am, what do you think? Means
So metformin, even in your presentation, has got certain positives. It is a kind of a metabolic stabilizer, if you want to put it. So yes, it can be used. It gives good results, but again, you do not get the same kind of results in all the patients that you try. It's easy to take. It's cheap also, so you can actually give it to anybody. The only thing is that how long, and I think we need to continue. We cannot have a end date, because if as sir mentioned, if the patient is stable on olanzapine, stability from the psychiatric side is most important. That is primary. So we are probably not going to disturb that dose of olanzapine which the patient is on. Psychosis are chronic states. So in this case, probably the treatment is going to be lifelong with olanzapine. Now, if we destabilize that patient, then the component of psychiatric illness which will contribute to the metabolic syndrome is also there, in terms of poor lifestyle, in terms of sedentary lifestyle, in terms of not working or not working out, substance use, and all that kind of thing. Then patients become non-compliant. So then or non-adherent, so they don't follow up. So all these things happen. So if a patient is stable, at least let us accept that stability. Let us add something which can, kind of help in weight gain. It can help in stabilizing the metabolic parameters. So one of the earliest strategies was metformin. Many people are still using it. It is a good strategy. Well, as I said, results will vary from individual to individual, as we know, but we will need to continue it as long as the weight has to be in control. See, people also age. So when people age, again, a lot of these things will come into play. Even aging is not very friendly for the metabolic syndrome, because with time, a lot of other changes will also set in. So it's better. My guess is, what happens with people who put on weight with olanzapine, as they become older, then they will have these other things definitely coming up. So if we give metformin, If again, it is all dependent on the BMI, because that table that you gave has got certain criteria. So it is again not only metformin, but we'll have to tell them if it's a stable patient and more likely to follow our advice. We need to tell them that what changes you need to make in a diet, common sense changes in the diet, common sense activity. Because for us in Mumbai, it is a big problem. You do moderate, you walk moderately fast 30 minutes a day. Then they say it's raining now. Then some people will say, then do it in summer, but it's too hot. So that kind of thing. So we have to be very practical when we advise lifestyle. So not only metformin, but we'll have to advise some lifestyle change also. So yes, it's a good practice, metformin, but yes, when are we going to stop it? Probably not. If there are side effects, and if we feel that that is inadequate and we need something else, then maybe we'll change. Even for PCOS, metformin is a good strategy. Because it keeps weight under control, weight remains under control, then all those other things that you mentioned, the androgenic effects and those kind of effects also are maybe relatively better.
Okay.
I would like to add here, personally, clinical experience wise, I have seen metformin is pretty useful, though it has its own limitations.
Yes.
So it could still be a worthwhile choice to
Yes.
give, and that is
Yes.
something that we do yet commonly give.
Yes. It's a very good strategy. I mean, as Dr. Maithili mentioned, all the newer drugs that we talked about are pretty costly. This is okay, not a problem.
Right.
So final comments, Dr. Maithili, from your side.
Yes, if we come towards the end, we had a very fruitful, and it was great to know. I'm sure there are a lot of take-home points for all of us, and I would like to thank the organizers for inviting me. I would like to thank our speaker, and yes, you, sir, Dave sir, for giving in so much of input, which has been useful for everyone who has been attending.
Thank you. Over to you, Dr. Rajkumar, sir.
Thank you, Drs. Malay, Dr. Priyanka, as well as Dr. Maithili for conducting the session today. And thank you all, friends, for joining in. We'll meet you again on the 10th of next month. QTC interval is the topic which is going to be taken on that day. Good evening to all of you. Good night to all of you. And thank the knowledge partners, Alchem CNS also. Good night to all of you.
Good night. Bye.
Good night.